Hello and good evening to everyone. Thank you for joining me. Today, I thought it was quite important to go back to the basics because sometimes I assume you know what I know. And so, therefore, when I speak about certain things, that you understand where I'm coming from. A lot of what I showed you before were some of the posts that some people really don't like me doing because it damages the narrative. And the reason that I think I have to do them is because if the narrative is not damaged, there is no incentive to go back to the science. Because there are so many important principles that we have to grasp about what happened in the pandemic, why did it happen, and what are the implications going forward. And I'm not sure if it is possible to be able to do that without actually going to the science. And so, what I had done some time ago, and it took a lot of time. I did a lot of recordings on it. So, in effect, I've put together what I think is probably the world's first completely comprehensive COVID Advanced 360. And in it, I captured most of my thoughts. This is an extremely huge course. We're talking about over 7 hours of content. And I had to sit down and put it together because I thought it was important to capture all of my thoughts on the research and put it in a place that it will then be a repository, because I suspect that in the next few years, as COVID goes further and further in the distance, very few people will remember what exactly happened. So, over the time, I've collected hundreds of slides. These are just some of the slides that I have from the 360 course that I have used together, plus others. So, we're talking about almost 300 slides that I have put together to try and explain the science around it. My challenge today is to try and simplify it in such a way that it makes sense to you. If you are listening to this here and now, I would want you to have a grasp of what happened in terms of severe COVID 19, and then you would understand why I continue to talk about the implications at a population level as to what happens when people have been, a population has been vaccinated and then gets reinfections. This is the bit that a lot of people don't quite understand. And it's important that when you reflect on what I say, you understand that I have always been cautious because I had a good understanding of the science. And so when there were moves early in 2021, there was a very clear high risk cohort, and they had taken out any other option other than the intervention. And so, therefore, if you're going to use it, please use it cautiously and judiciously, and make sure that you follow for the consequences. The bits that then happened were that they broadly did it across the population, which to me was just absolutely dangerous. That was a huge gamble. And secondly, it didn't actually stop the circulation. And so we went into uncharted territory. And the uncharted territory is what happens when there is recurring reinfections. This is where we are now. So I am worried that we are facing consequences that we couldn't have anticipated, and we're not looking for it. So let's get you to some of the science. And I'll just take you through this. This is only a few slides from the whole presentation. If you want to take that course or just be registered for it while it's at a huge discount, because it will be there for life. And if I add any more content, you'll still be able to have access to it. So it's a useful thing to have on your fingertips. So let's start with some basic things. There were 5 cohorts that I described in terms of severe COVID. There was the asymptomatic cohort, which was actually quite a large cohort. But asymptomatic is the wrong word because for many people it was subclinical, and you'll understand why. Then, with the Omicron variant, you had COVID bronchitis, where people would have this 100-day cough, and that was inflammation in the upper airway. This bit causes a lot of confusion because there is a viral pneumonia that occurs with the infection. But for most healthy people, it doesn't cause them much problems. But if somebody already had underlying lung disease or other comorbidities, this could have been a very serious infection. What made COVID, moderate and severe COVID, unique was the presence of microclots, which we will come to. Microclots, not so many, was moderate COVID. Microclots, severe microclots, was severe COVID. This was the cohort that died. And this bit is what then made the whole world panic because they didn't seem as though they could understand who was at risk for this severe response. And therefore, the perception was because you're not sure, give everybody. And that was the thinking. But it wasn't based around the science because the science told you that there were some very high risk cohorts. And some people still argue today that everybody is at risk. And again, it's because there's a failure to understand the science. And the reason they say that is because there were some younger people with no apparent comorbidities who got severe disease. That is an issue, but we know the science, interferon autoantibodies. And so if you spent the time looking to identify those people, you would have been in a better position. But the principle of the science also indicates that we should have been able to intervene with other therapeutics. And this is what caused a lot of the censorship throughout the world, because it's almost as if they didn't want there to be anything else. Because if there was, you couldn't then mandate the intervention. That's fundamentally it. So let's get back to a little bit of the basics around the science. As you know, this is the SARS-CoV-2 virus here. It goes into the upper airway, binds to receptors, usually in the nasal epithelium, where it then infects the cells and then it spreads out and in. And the critical thing is that you don't want it to start bouncing around in the bloodstream, because once it triggers a systemic response in some people, that's what then leads to severe disease. So when we had the cohort, and they're still around, and they can be either vaccinated or unvaccinated, who say they have never had COVID, what they mean is that they have never had any obvious symptoms related to the infection because everybody has been exposed. But for some people who have very good mucosal immunity, even when the virus infects and tries to replicate, the immune system then takes out those infected cells. And so they will have a mild or asymptomatic infection. But it's important to note that this perceived mild infection, when we looked at the science in terms of there were people who had apparently no symptoms, but when you look at their lungs, in their lung pathology, there was still quite severe inflammation. And it just didn't cause them many symptoms. So that cohort would have had what they thought were mild symptoms, a little bit of a temperature. They felt a little bit achy for a day or two, and then they went back to normal. But it wasn't because the virus didn't get down into the lungs. And the mechanism as to how it caused inflammation is the critical bit of information. So you can see on the left here, the healthy lung. You can see here the inflamed lung, where the virus has gone and caused generalized broad inflammatory responses. And when they did the tests on macaques and they infected them, and then they did imaging within 48 hours, this is what it would look like. This is normal, day 0. Within 48 hours, this is what it looks like. And these animals only had very mild symptoms. They only had a bit of a temperature, they were a little bit lethargic. And so, this is the important differentiation. The people who had absolutely no symptoms, where they didn't even have a bit of a temperature, didn't even have a little bit of fatigue, they're the ones who probably got control of the virus in the mucosal epithelium immediately. And that suggests that they had good, strong mucosal immunity. The people who had mild symptoms probably had subclinical inflammation. And depending on the variant, they could have gone on to have the bronchitis. And then, if those people, even with the minor symptoms, if they had underlying lung disease, they could have still ended up with a viral pneumonia with secondary bacterial infection. But it wasn't necessarily severe COVID. Now, the critical piece of the puzzle, and as long as you understand this, this helps you to know not only what caused severe disease then, but why I say almost categorically that we will not see that kind of presentation again with this virus. Okay, it's important to note with this virus, severe COVID, the way it presented with that rapid deterioration about 7 days after the original infection, ending up on intensive care with specific patterns and microclots, is very unlikely to happen at this stage. Follow now. What happens with the virus is that it is exceptionally good at blocking interferon. And interferon is your warning signal. This is what tells your immune system that there is an infection present. If you imagine, it's like if you imagine a dark prison and a prisoner is trying to escape and he jumps over the wall and triggers the alarm, and suddenly all the lights flick on and the alarm starts to sound. They haven't caught him yet, but straight away, everybody's on alert. A prisoner is escaping. They will then track him down into the woods and they'll capture him and bring him back. That's what interferon is. When a virus, any virus, infects the body and some bacteria, it triggers the immune system on alert. And so the immune system lights up and goes, there's virus present. We need to be ready. What happened with SARS-CoV-2 is that it was so good at evading the interferon that it would be like the prisoner getting completely out of the prison, out into the field, into the forest, getting on the road, and then he's met by the police and they call the prison and then they overreact. Lights go on, alarms go off, people are running all around, because you shouldn't have somebody get that far without being picked up. You can flip it around. The bunker of the White House. If a burglar ever got down into the bunker of the White House, it would trigger the National Guard because it shouldn't be possible. That's the premise. The virus should never be able to get down into the lungs without triggering that interferon response. And when that occurs, it triggers an overreaction. Now, I'm going to show you a slide here for which is really important to grasp with regards to interferon. When the studies were done with SARS-CoV, and they did this in mice in 2016, so this is how they worked out the mechanism of severe disease. And what they found was that if the mice then had an early interferon response, even though they still had the infection, they would not have severe disease. What was very interesting is that even if they had no interferon response and a big surge of virus, they still wouldn't have severe disease. What caused severe disease was a delayed interferon response that was strong. So this is what caused people a lot of confusion. They kept on saying that if you've got good immune systems, you won't get severe disease. Actually, the people who got severe disease had a good immune system. It was just that it was delayed. And that delay caused an overreaction of the immune response that led to severe disease. Fundamentally, that is SARS-CoV-2 severe disease in a nutshell with interferon. And therefore, the reason why I say that we're unlikely to see that again is because everybody has been exposed. There is no longer the ability for the virus to be that novel and get down into lungs without triggering interferon. That's the hope. One of the things Gert pointed out, however, is that there could be a variant, and there is one I just read about in the past few days, that is able to evade the immunity. And in theory, it should or could be able to do that. But I still think that's unlikely for it to cause that pattern of disease that we saw early on in the pandemic. There's a part of the puzzle that I'll only mention, and this is part around my research, which was about autoimmunity. Because all we said in our research was that if the virus then gets into the bloodstream, binds to free serum ACE2 in people who have it, diabetes, hypertension, heart disease, kidney disease, then picked up by the immune system, it can't differentiate the virus from the ACE2, the free floating ACE2, and then it would trigger autoantibodies, which would target the lining of the blood vessels, especially in the lungs. And this is essentially all we said was severe COVID-19. It was an autoimmune inflammatory response. Now, some people will say, well, they disagree with its autoimmunity. I won't get caught on that. All you have to concentrate on is that there was an inflammatory primarily involving the blood vessels in the lungs. Also involves some other organs, but mainly in the lungs. And when you look at what was different in terms of COVID versus others infections, this is on the right here is a normal chest X-ray. Dark means there's a lot of air. This here is more solid organs, light up a bit white. So this is the heart. And this person here, this is breast tissue down here. And so you can see here that the lungs are relatively dark, which means they are full of air. In this image here, this is a pneumonia on the right-hand side. And you can see that in this case, this part lights up white. That's because it's filled with fluid and so on. It's inflammation. And over here, you have COVID. The characteristic about COVID was that it was bilateral, very diffuse changes. And this is part of the reason why it was more of a vascular problem. And actually, one of the radiologists demonstrated, and it took 4 years for his paper to come out, that in effect, when he looked at the CT scans, there was very little inflammation involving the bronchi and the bronchioles. These changes were all primarily because of vascular changes. That now takes us to that principle about the microclots. So there are two things. One, interferon evasion is what triggers the inflammation. And that can happen even with subclinical infection. So the inflammation on its own is not enough. There needs to be also another trigger for the cytokine storm for the immune system to start attacking blood vessels in the lungs. Let's not argue about what that mechanism is, but I'm just taking you through exactly what happens that causes the symptoms associated with severe disease. What then happens are these microclots. So inside of the blood vessels in the lungs, you then have a clot that blocks the blood so that the blood can't continue to pass through. But these are occurring in very small blood vessels going to small areas of the lungs. It's just that if you have loads of them happening, that's what causes the symptoms of severe disease when someone can't breathe. An interesting sideline on that is one of the reasons why vitamin D was beneficial in severe COVID is because if your vitamin D levels are low, you are more prone to clotting. And this is not just COVID, this is any disease, for thromboembolism, from PEs, DVTs, strokes. If your vitamin D levels are low, your body is more likely to make clots. And so by increasing the vitamin D levels, in theory, you would have reduced the amount of clots that somebody would have had. And this is why vitamin D would have been beneficial anyway in the pandemic. I still cannot explain why they never went forward with it. Can you believe in the UK, the health secretary planned to do that? It was his intention to broadly give vitamin D to the whole population. And I have no idea how he got taken out of the idea from doing it. It was so strange. I don't know why anybody would do that. It's such a simple intervention. And even if you didn't believe it helped, so what? Vitamin D is an essential vitamin and it should have been given to almost everyone. And so remember that point. If you're not taking it now, you please make sure your levels are fine. So these microthrombi would then block tiny blood vessels in the lungs, causing little areas of the lungs to not get oxygen. And so it wasn't inflammation in the bronchi or bronchioles. It was the fact that blood could not get to different parts of the lung in order to get oxygen. And this is why patients who were even on intensive care on 100% oxygen still died. And so there's a picture that I use to try and help clarify that point, and it's here. You have to remember that your lungs are composed of multiple tiny alveoli. And this is what it would look like. This is an alveoli. And literally, this capillary is about one blood vessel thick. But this is where the oxygen comes in and the carbon dioxide goes out. So it represents the unit of the lung. And you have probably about 48 million of these alveoli between two lungs. So what happened in, say, moderate COVID, little clots were forming that would have taken out almost 80% of these alveoli. And so these people would be struggling to breathe. They would need oxygen. They would be on steroids to try and settle them. But they would have had moderate COVID. And this cohort largely was able to get beyond the severe disease. However, if you ended up with almost 90% of the alveoli destroyed or taken out with the clots, no amount of oxygen will be able to oxygenate just these few alveoli left to keep someone alive. And this is essentially why, and it was so strange when you looked at it clinically. You know, somebody's on a ventilator, they're only getting oxygen and they still can't be oxygenated enough. The only thing that can do that is the lack of blood to the alveoli. Even with a pneumonia from a flu, which doesn't do that kind of response with a high amount of oxygen, unless they have underlying lung disease, they will often survive. So if you had a 30-year-old with no comorbidities, had a very severe flu or infection on the chest, and they were on intensive care, it's not impossible, but certainly you would expect them to make it with the oxygen. What we were seeing in COVID is that even younger people who had no apparent comorbidities couldn't get enough oxygen on a ventilator. And that's largely because they would have lost the majority of their alveoli not having blood getting to it. And that's essentially severe COVID-19. And that's why, in my view, this could have been managed. This could have been treated. It did not have to cause the amount of death across the world if it had been understood. Now, the problem is that people think, well, it's behind us. Does it make any difference? Well, if you accept that this cytokine storm was primarily inflammation of the blood vessels in the lungs, then you have to be concerned about what happens on reinfection. And this is what I am talking about now, is that I've moved beyond severe COVID-19 to say, what happens if that kind of inflammatory process happens in other organs? What happens if it happens in the brain, the tiny capillaries in the brain? What happens if it happens in the tiny capillaries in the heart or in the kidneys? How will it present? What diseases will happen? This is where we need to be now to try and understand what is happening. In the past, we had this: a big cohort, asymptomatic or subclinical, some people having a chronic cough for about 2 or 3 months, some people having a pneumonia with a secondary bacterial infection. And if they had lung disease underlying it, or if they were significantly immune suppressed, they could go on to die from just this viral pneumonia. But the big hitting one that caused the severe disease was the microclots with moderate and severe COVID-19. That's what is very unique in the presentation of the disease. This information, as I said, is extremely important. And in time, hopefully, we can get enough people to understand that science, because when it's understood, one can then predict going forward what is it that can happen and how can we mitigate it. That's part of the reason why I am focused on places like Haiti or Papua New Guinea that escaped without being vaccinated. So we know that the vaccine had an impact on severe disease, but we couldn't know what was the longer term impact, certainly with reinfection. That's a whole different ball game. But if you have areas that can demonstrate that you didn't need to intervene, we need to understand what those mechanisms were. And if you've seen any of my recent presentations on, say, Haiti, you will know it's probably, in my opinion, from a scientific point of view, it's likely to be related to something that rhymes with pectin. You can then understand what that is. And so, in terms of what it is that you need to do now, is that you need to firstly not be afraid, because with understanding comes an ability to intervene and to try and help and to make a difference. And a big part about what can be done, and this is where the medical and scientific community needs to come on board, is that if there is an understanding of that inflammatory process happening in the blood vessels, particular targeted immune suppression and other mechanisms can be used to reduce the risk. But you have to recognize it, you have to understand it, and you have to be willing to do something about it. That's where I think that at the moment, everything is getting stuck. We need a new paradigm in terms of what we do, how we do it, when we do it, in order for us to make a difference in the longer term. I hope that this is something that you can stick in your head, because at the end of the day, if you understand it and you can share it with others, it helps everyone in the long run. Have a great evening.